Hi everyone, it's very nice to be here. It's my first time talking at the adult retreat and it's a real pleasure to be able to do so. So I've been to the scientific meeting for about 8 years running. But just so that I can know who's here, would you mind putting your hand up if you have an FA diagnosis? Parents? Partners? Great, thanks. Anyone, any groups that I missed? So before we start, I'll point out that I'm a scientist, I'm not a medical doctor. So I think that's helpful just to keep in mind. There's no medical advice here today, it's just a discussion about what we know, what we don't know, and I hope that we have lots of time for questions at the end. Before we start, I'd like to point out that dealing with fertility challenges is a sensitive topic. I don't want to minimise that at all. Whether it's in the context of Fanconi Anemia or not, most parents often find it uncomfortable to talk about fertility and family planning with their kids. Getting pregnant is generally not easy for anyone. This is a common problem for the general population. The definition of infertility is 1 year of trying to have children and being unsuccessful, and so 20% of couples around the world meet that definition. Also, even in the second year, it's still 14% of couples worldwide. So it's a big problem for the general population as well as in Fanconi Anemia. I thought it might be nice just to start with a little bit of anonymous audience interaction for anyone who would like to do so. I have 3 questions which are very general, just about your views on research priorities, fertility, things like this, and it's multiple choice. So I'm sorry that I won't be able to, I can read out the results in real time, but I won't be able to show them on the screen. But we'll just give it a moment for you to put in answers. So that for those of you who might not have a phone on you, I'll just tell you what the question is. So the question is, on a scale of 1 to 5, how important is fertility and reproductive health as a research priority in FA? And this is recognising that not everyone is interested in this topic and maybe other people are very passionate. So we've got answers coming in, very quickly centering around 4 out of 5. So we've got 18 votes so far and 40% of people have said, keeps moving, everyone keeps voting. Okay, it's quite clear that the number that this sits on is 4 out of 5. So it's not a 5 out of 5, it's 4 out of 5, so quite important to many. There are people who say 1, like not important at all. So 9% of people said not important, that was a 1 out of 5. 9% said 2 out of 5, 13, 3 out of 5, 48%. So half the people in the room said the cheeky people that keep voting. So 46% say 4 out of 5, and then 25% say 5 out of 5. So let's move on to the next question. So the next question is, which of these areas do you think researchers should prioritise most? Options being fertility and reproductive health, cancer risk, treatment side effects, quality of life, or other. 24 votes so far, 50%. Cancer risk and quality of life are coming out quite close. So cancer risk 44%, quality of life 37%, fertility reproductive health 15%, treatment side effects 4%, 0% other. Very, very close cancer risk and quality of life. And that's really helpful for me to know too. I think that we saw yesterday in the opening session just how important these discussions around quality of life are. So thank you for that with 28 votes. And the next question and final one is about when researchers study fertility in FA, what aspects are important to you? So understanding risks, and this can mean like risks in pregnancy for women, fertility preservation options, support around decision making, or other. Okay, so far with 25 votes, we've got 36% preserving fertility preservation options, understanding risks, the next ranked, and then the third was supporting decision making, and 7% other. Thank you very much for that. I found that really helpful. I hope that it's interesting for you too. A lot of what this talk is about is just a little bit of an overview of how we make cells for reproduction and what we know about this in the general population and in the context of FA. We'll move on to fertility challenges in FA that might be linked to making these reproductive cells, and then what we do and we don't know about FA. In particular, what we would like to know about use of assisted reproductive technologies, so things like IVF, and what we do or don't know about men with FA and fertility. So just a tiny little bit of background about sort of like how these cells in our bodies are made, so the things that are the precursors to sperm and eggs. When we're developing as a baby, so this we're talking about ourselves and a person who is one day maybe going to be able to have children. The concept that I want to discuss is just that. So the testes and the ovaries are effectively the same organ, and then it's not until later in development that it's sort of determined whether those organs turn into testes or ovaries based on whether or not you have a Y chromosome. So sort of like we start off generally, the default state is ovaries, and then when a Y chromosome is present, that turns on the machinery to what we call masculinize. And this is meant to be biological, this is not about how we identify. And then the one other thing that I wanted to touch on briefly is about the production of our reproductive cells. So blue line is boys and the red is for females. When we are developing in utero, what happens is the number of reproductive cells that we have, or potential reproductive cells, and this is in the general population because that's where we have more knowledge, this goes up as we are developing as babies. And then in women, so it's normal that the number of reproductive cells, so they're called follicles in women, things that can go on to become eggs, it's natural that they go down over time, and they go down quite quickly, and this happens in all women. And then for men, this is a bit of a generalization, but the ability to keep making reproductive cells continues throughout life. So focusing on women, what happens is, as I was mentioning on the previous slide, the number of reproductive cells goes up incredibly quickly, but actually starts to come down even before a female is born. And then it continues to go down over life. There is a window in the general population of women where optimal fertility might be between 18 to 31. And when I say optimal, we're talking about biology, we're not talking about the practical aspects of life. When we have children these days, then fertility starts to go down in the 30s. There is a sort of an end of natural fertility, and then menopause occurs at around the age of 51 in the general population. Things that affect these ovarian reserves are, as I've shown here, age. Other things that affect the ovarian reserves are genetics, and an example of that is Fanconi Anemia. And then chemotherapy, so these what we call cytotoxic treatments, so chemotherapy, bone marrow transplants, I think that many of you will appreciate and hopefully have spoken to your doctors before these treatments, their effect that they can have on fertility. But there is not always, these conversations don't always happen, but I think that's something that we could talk about today. Now, so this data here is a generalization for the broader population, and I've drawn some lines here that sort of represent uncertainty. Women who have a Fanconi anemia diagnosis, that we know that there are less follicles, so things that can make eggs. Exactly where that sits, we don't know, and it will probably depend on a number of factors, just like it does for every woman. And so you might hear the term primary ovarian insufficiency in the context of FA, and what this refers to is the idea that the number of follicles that are available for reproduction will undergo attrition, which is effectively sort of naturally becoming unavailable over time, and so the window of fertility is shorter in FA. What we do know about pregnancy and Fanconi anemia is that there are some women with FA who can get pregnant, and there are people here who have had children, and people who are grandparents in this room, like they've had children who have had babies, and we know that generally that the babies that women have had with FA are healthy. We don't have evidence to the contrary. There was maybe a slightly increased rate of miscarriage, and so some things just to consider is for someone who is thinking about getting pregnant is just to make sure to involve your medical team and to talk about this ahead of time, because any treatment that you have would affect not only you but also a developing baby. Something that a medical team can help with is to estimate these ovarian reserves that I was talking about on the previous slide, and the way that they do this is measure something called AMH, which is circulating in the blood, and so that stands for anti-Mullerian hormone, and it's just a very good way of measuring an estimation of the amount of follicles that are in the ovaries. And the other thing that a medical team would also look at is blood counts, because blood counts are affected by pregnancy. Because what happens when a woman gets pregnant is the total volume of the blood goes up, and so that does put pressure on the blood producing system, hematopoietic system. So what we have here is a chart of blood counts from a woman who was pregnant and delivered a baby. What you can see here is, I'm going to assume that most people here are pretty good at reading blood charts compared to the average person. So if something that I have learned is that parents and people with FA are incredibly good at reading blood charts compared to the average person. But you can see that her hemoglobin goes down, and then the reason that it goes back up is those vertical dotted green lines are where she had transfusions. So you can see that her hemoglobin and platelets are going down, but she has transfusions at these different time points in pregnancy. Things start to stabilize again after she has given birth. But this just highlights the pressure that it puts on the blood producing system to be pregnant. And something that was also noticed in this study from Blanchard, which was published back in the early 90s, so it's a little bit dated, but it's still very good information. Many of the women in this study who had children were diagnosed with their FA because they got pregnant. And that relates to the hematological complications that can occur during pregnancy. Something that was speculated but hasn't been proven to be the case was that maybe also a consideration is that the baby's head might be quite large with respect to the mother's pelvis in the case of FA, but this was something that they raised as an idea, but I don't think has been tested, so it's not demonstrated to be true or false. It was just an idea that was brought up. Okay, and then very briefly talking about how sperm is made. So this is, if you imagine a cross-section of the testes in a cartoon. What we're looking at here are these things called tubules or seminiferous tubules. What happens in males and how they make these cells is that in these tubes you have the stem cells around the outside, so just on the inside rather, of these tubules, and then these undergo development and can turn into sperm, which move to the epididymis to mature. In the context of FA, there are very, very limited studies about sperm production in men, but what we do know from the studies where they looked at this is that what they saw was that they have this sort of can have this mosaic production where some of the tubules are empty and others can be producing sperm maybe at lower rates, but this is very, very limited to maybe 3 or 4 studies that have been done. So we don't know if this is generalizable or not. But things that are good to know about if someone is thinking about starting a family is these are things that are quite easy to measure at a fertility clinic, things like sperm number, and then also quality of the sperm as well. So things like their shape, their motility, meaning whether they swim or not and how they swim, and then also DNA fragmentation is something that can be measured. So this is something that's done for all people who might do some of these tests, not just in the case of FA. So this is a brief summary of what we know about production of reproductive cells, but this comes from mice. May or may not apply to people, but it's the best sort of knowledge that we have at the moment. So this is a cartoon of a developing mouse embryo, and you have these little precursors to reproductive cells that are in this part of the developing embryo. Eventually they migrate here, and then they start to expand out. And what has been seen across the different mice that have been made, so the different groups, like Fanc A being the main group and others, is that, so this often will happen in a similar way, but just a lower number of cells. And then this will then impact both the male and female mice that have been studied. And so a possibility might be that what happens is that things that happen in FA reflect what happens in the general population, but maybe at lower rates, although this is something that's understudied in FA compared to other areas, but this is the best sort of working models that we have today. So now I just want to move to talking about assisted reproductive technologies, and before talking about that, just want to point out that the decision to use these things is very personal, and it's a factor of many things. So it depends on where you live, culture, politics, the economic means that a country and an individual has, regulations, and so on. So some of the options that exist involve cryopreservation or freezing of sperm and eggs. Another option is in vitro fertilization and also artificial insemination. So these are all things that can be done separately or together for different reasons. Something that I'll point out is that we're fully aware from talking to you, people in the community, we know that in particular women have used these technologies, but we don't know this from the scientific literature, we haven't read it in papers. If anything, I've learned more from talking to people, but I suppose that's not information that can be shared, particularly with healthcare providers, if it hasn't been sort of studied in a scientific way. But I'd love to discuss this more. So I think the first thing to understand is that it doesn't always work. And something that you might want to consider asking a healthcare provider if you're thinking about some of these approaches is what defines success. So sometimes if you talk to an IVF company, their definition of success is getting pregnant, but I think that most people's definition of success is having a baby. So that might be something just to be aware of if you look at any advertisement material. In terms of cryopreserving ovarian tissue, this is something that can be done at any stage in women, even before puberty. There are many cases where a woman, a girl or a female prior to puberty has had some ovarian tissue preserved and can be used to have a baby later. Egg retrieval is something that can also be done. Embryos can be stored. In terms of success rates, as I said before, we don't have this information, how it compares to the general population. And for men, cryopreservation of sperm can only be done after puberty with some idea that success can happen. Freezing anything before puberty is purely experimental. Maybe it could be used in the future, and we're waiting on scientific advances that haven't yet happened to be able to use that material to conceive and have a baby. So for men with FA, some questions to ask and things to consider is that there has to be sperm present in order to be able to preserve something to hope to be able to have successful IVF down the track. Other questions would be how is the financial cost covered, and to also think about not just upfront costs but also ongoing costs, like what are the costs to store per year. It's a personal choice, and many of you in the room probably have already experienced this, that parents sometimes have to make the choice if a treatment is going to happen, such as a bone marrow transplant or a cancer treatment early in life, prior to being an adult. Parents might have to make this decision. They might have to make the decision with a lot of time pressure as well. So it might be worth just thinking about this, if this is relevant, you or someone who this could relate to think about it now when you have some time in case a rapid decision needed to be made in the future. And then in terms of surrogacy, that is where someone carries a baby on behalf of someone else. Those laws vary dramatically by states and by countries. So this is just a picture taken from Wikipedia around the world, around the US, showing what the laws are like with respect to surrogacy, where, for example, speaking for Australia, where I come from, surrogacy is legal, but it can only be done altruistically. That means where someone does it just because they want to help someone else out. So maybe a sister carries a baby on behalf of her sister, and no money is going to exchange hands. There's a territory in Australia where the laws around this haven't been legislated, and then you can see throughout the world, and you can look this up yourself on Wikipedia just to see what applies to where you live if this interests you. And also, like I said before, but not everyone is interested in having kids, be it with FA or without, so maybe none of the above applies. So what we do know and what we don't know, based on scientific studies, not based on anecdotes, is that some women with FA can have children naturally, and these babies are generally healthy. The natural window of fertility in FA generally stops around age 31 in women, and that the pregnancy in FA can pose some risks, and so if you were considering getting pregnant, is to talk to the medical team that you have before then. And we don't know, there's a lot that we don't know, but whether or not men with FA can have children naturally, again, we know things anecdotally, but in the scientific literature we don't know much, if anything, about whether this is possible. And if so, are the babies healthy? What is the sperm number or the quality like? And is it better to, I think this is something really important, is it better to preserve sperm or eggs as early as possible to understand and share this information for other people, just to understand what outcomes are like freezing these cell types at different ages? And also, can these sperm and eggs be used in IVF in FA? Can they be cryopreserved? Can embryos be cryopreserved? Can egg retrieval be done safely? And also, can reimplantation be done? So I'll just leave it there, and thank you for your attention. I'd love to take any questions.
Sorry if I missed this already. And thank you, this was super informative, super. Both of my kids have been through transplant, and they didn't have radiation, but they did have chemo. How does that affect their chances, obviously, on top of what you presented?
Yeah, so obviously I can't speak to an individual's circumstances, but what I do know is that there is one study that focused on fertility recovery in females after transplant. So there were a number of women who could conceive after transplants. So it's not a given that someone won't be able to conceive after a bone marrow transplant, but it does decrease the likelihood. And for men, there's no information.
Just a quick question. I know a lot of the FA females go into menopause super early, like teenager, super early, but then are put on hormones to maintain a cycle for their bone health and things like that. Does that supplementation have any effect on fertility?
I couldn't answer that with any certainty. I don't have a great understanding of that type of endocrinology, but if you like, I'd be happy to help direct the question to someone who could. Yeah, but with respect to going into menopause early, when I talked about numbers like 31 in FA and 51 in the general population, these are averages. So that means that there's roughly 50% on either side of that number.
I just had a question. Why is there so much less information about men as opposed to females?
Yeah. Okay, so this is not a problem that's specific to FA. across research in medicine, it's harder to engage men in general and specifically to talk about issues like fertility. It's a topic that's uncomfortable. We all have our own things that we are more or less likely to talk about. And yeah, that's just from talking to other researchers, it's a pattern across research. You can encourage the men to get involved.
I just want to find out, as far as I know, and my wife has researched that we don't know of any FA male that's ever had children. Is that true? Number one. And number two, is there anything done about that? Is there any trial runs? Is anybody doing anything to see whether there would be a chance of maybe some added medications or drugs or any other surgery or anything that's being done to up the chances of somebody that has FA that's a male to maybe one day have children?
Yeah, good question. So in terms of, there are a couple of papers that, it's really not the focus of the paper, but there are some papers about things like head and neck cancer where they just mention that this man has had children. So there's one or two papers from Agatha will talk after this, where she has mentioned this in her paper, but so there hasn't been a study. What we know is that it must be a minority of men. I can tell you from anecdotes, there are clearly men that have had their own children with FA, but I couldn't tell you about numbers. I mean, Agatha and I proposed a project which unfortunately was unsuccessful, but we proposed to do a very simple survey in addition, and then follow-up studies to ask a very simple anonymised questionnaire to as many people as possible, to adults with FA, men and women, asking questions like, have you tried to have children? Did you succeed? Is this something that's important to you? And so on. Very simple anonymised questionnaire, because we would love to have good information on this. Because we don't know is the answer, is it 2% of men who've tried? Is it 10? Is it 20? I just can't answer that with any certainty. In terms of the last question, is there anything that would help? I don't know of anything. Again, that's why we would do a study to find factors that are associated with improved outcomes or not. I mean, I suspect it has a lot to do with the individual already, like some of us might be more or less likely to be able to. Whether or not there are any treatments that can help, that would be a question for future research.
Right, so if any trial runs open up, phone us.
Of course, yeah.
I'm also going to take that as an opportunity to plug the registry, because we do ask a couple of fertility and reproductive questions in there. So all men, put your information in the registry so we have it.
All right, thanks very much. And for those of you who haven't met before, please come up and say hi afterwards. I'd love to meet everyone. Thanks.